Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. Today, we're going to focus upon the 2022 ACC AHA guidelines for heart failure, which was just published a couple of days ago. That is on April 1st, 2022. That's about 10 days ago. So, we're going to look at primarily the medical treatment of heart failure because that's the most important aspect for practicing physicians, for internists, and for family practitioners. So you have a broad knowledge of what heart failure is, what are the stages of heart failure, what kind of symptoms they have, and what drugs are available to treat these patients at various levels. And think about the interactions and side effects and some of the harmful effects of the drugs that we use for treating patients with heart failure. So let us begin with the feature presentation. As you know, heart failure is divided into various stages. Stage 1 is where there is some structural changes. They generally do not have any symptoms. They may have reduced ejection fraction, but they are functional at mild to mild activities. Stage 2 is where they have mild symptoms. Then stage 3 is where they have moderate symptoms. Stage 4, of course, is symptoms at rest, and 5 and 6 are sort of a moribund situation. So most of our focus is going to be on patients in stage 2 to 4, those patients who are having symptoms, who need medications to optimize their function, heart function, and their symptomatology. So if you look on the left-hand side, you can follow my green arrow here. If you look on the left-hand side at stage 1 or stage 2, where the ejection fraction is less than 40%, or if it's a preserved ejection fraction with more than 40%, if they have evidence of a heart failure, we have a variety of options available to treat these patients, including ACE inhibitors, ARBs, ARNIs, beta blockers, and the SGLT2I inhibitors, along with diuretics. As you know, the diuretics have been the mainstay of treatment of patients with heart failure. Even to this day, diuretics are of great importance in managing their fluid balance, especially when they are fluid overloaded. At the same time, we need to be concerned about depletion of the intravascular volume with aggressive diuresis. So let us look at each one of these drug categories and see how they fit in the various stages of heart failure, because not all drugs are used in every stage of heart failure, because when you get to stage 3 or 4, we use certain drugs which are generally not used in patients with the stage 1 or stage 2 heart failure. Keeping that in mind, let us move on and look at a very important chart. I put this chart first in order for us to understand if we are going to give a drug to a patient, how good is the drug in reducing the symptomatology, improving the quality of life, and improving mortality. So this particular chart looks at the relative risk reduction in mortality with various groups of drugs. For example, ACE and ARBs reduce the overall mortality by 17%. With ARNIs, it is 16%. But with beta blockers, there is a 34% reduction in mortality, especially attributed to the drugs like carvedilol and its analogs. Then we have the mineralocorticoids like aldactone or eplerenone, which show a 30% reduction in mortality. Then when we come to SGLT2, which has a 17% reduction, but at the same time, we have to understand these drugs are used not just in isolation, but these drugs are used in combination with all other drugs. So this added benefit is of paramount importance in reducing the overall morbidity and mortality in these patients. And of course, these are mechanical devices like the CRT or cardiac resynchronization therapy or ICD, and they are the mechanical ones which we are not going to talk about. Basically, this presentation is going to focus upon the medical management in the hospital, at bedside, and in your clinics, as how do you manage these patients, what drug do you use, and what is its benefit in terms of reducing symptoms and mortality, and what are its side effects, and what are its interaction with other drugs. So let's take a deeper look into each one of these classes now. Diuretics. All of you are familiar with the diuretics. I'm not going to bore you with a lot of diuretics and drive you to dehydration. And we have basically two types of diuretics that are available: loop diuretics and thiazide diuretics. In loop diuretics, it is not uncommon for patients routinely treating heart failure to be familiar with all these three drugs, namely furosemide, bumetanide, and torsemide. In patients where furosemide doesn't work, then bumetanide or torsemide may have a better effect in reducing the sodium, reducing the volume, improving the symptoms, and improving the quality of life. And here are the dosages, which I'm not going to really go each one of these individually, but I do want to tell you that I have put the reference to this JAMA Jack article, which is free, which you can download. It is 159 pages long, and all these charts are taken from this great Jack article, to which I am greatly thankful to the American Heart Association and for the American College of Cardiology to make this available to every practicing physician in the United States without having to jump hoops. And that's the way medicine should be practiced. All these important guidelines should be actually mailed to every practicing physician so that we are all on the same page. So you can go to this reference, download this article, and save it in your library. Now, coming back to the diuretics. These diuretics are can be given once a day, twice a day, and torsemide is like once a day, and here is the maximum dose and the duration of action. Duration of actions are very important, especially if you are treating these patients in a hospital setup, because you may have to know how frequently you want to repeat the dosages. Among the thiazide diuretics, the one that has been shown to reduce the hospitalizations mortality is the chlorthalidone, which is given in a dose of 12.5 to 25 milligrams daily, and the max is 100 milligrams. In fact, even hydrochlorothiazide has been shown to reduce the overall morbidity and mortality. So you can look at these dosages, and I would say stick to one or two drugs in each class. That's it. Because you're not going to use too many drugs. It's too complicated to keep track of every drug. If furosemide doesn't work, you may try bumetanide or torsemide, and more or less these drugs, when they go into mega doses, they are generally managed by specialists like cardiologists or nephrologists because of significantly elevated creatinine levels. But it does help you to understand when to refer these patients to a specialist, because the diuretics play an important role in the management of patients with various stages of heart failure. If they have volume overload, they need diuretics. They need the appropriate amount of diuretics so you don't over-diurese and put them into pre-renal azotemia. Okay, as I said, hydrochlorothalidone has been shown to show improvement in morbidity and mortality, and metalazone is a very important diuretic which I use routinely in patients with heart failure when needed, because when metalazone is combined with furosemide, then we get a added benefit effect. Whereas if furosemide was not working, adding metalazone would greatly enhance the diuresis and thus improve the volume status in patients with persistent resistant heart failure. Now let's move on to ACE, ARBs, ERNIs for treatment of heart failure. Again, if we look at that, we know from previous studies that ACE and ARBs do improve symptoms, they improve the quality of life, and they also reduce morbidity and mortality. The similar picture is seen with ERNIs also, and those are some of the important aspects that we need to keep in mind. In patients who are not able to tolerate ACE or ARBs, they can be treated with direct renin-angiotensin inhibitors, and you can get some added benefit. And let's look at some of the situations where these drugs may not be useful. ERNIs should not be administered concomitantly with ACE or within 36 hours of the last dose of ACE inhibitors. So keep that in mind. If these patients are on ACE inhibitors, then you need to wait for 36 hours before starting these patients on ERNI. ERNI should not be administered to patients with a history of angioedema, which is sort of similar to those patients with allergic reaction to ACE inhibitors. Again, ACE should not be administered to patients with a history of angioedema. That has been sort of become etched into medical textbooks. That's something we don't need to worry about. So let's look at what are the drugs available in these categories of ACE, ERNIs, and ARBs. As you can see, we have the ACE or ARBs with the this is again looking at the chart. I keep looking at this chart of morbidity and mortality improvements with each class of drugs, ACE and ARBs, 17% to 16%. Keep that in mind because that's what you have to think about when you use these drugs, because some of these drugs are expensive, and if you can get a generic drug that has a better morbidity and mortality and that costs very little to the patient, that should be the choice for a patient with heart failure to begin with. Okay, here are the drugs, ACE inhibitors, a long list of ACE inhibitors. The only couple of drugs that I routinely use are like enalapril. That's one of the most frequently used drugs because every other drug was tested against enalapril. So I'm convinced that enalapril is, if it is effective, it will do the job, and the dosages are given here starting 2.5 milligrams up to a max of 20 milligrams twice daily. And of course, lisinopril is very popular because when I was working at the VA hospital, that was one of the main drugs that was available in the ACE group. So I prescribe that also quite frequently. The max dose is like 40 milligrams once a day. Generally, I feel when they say once a day, it's better to split the dose and give it twice a day. In that way, the side effects are less and the blood levels of these drugs remain steady for a longer period of time. You can also use any one of these drugs. It's a matter of you cannot master every ACE inhibitor. So you're better to stick to, like I stick to enalapril or lisinopril because those are the ones which are most frequently used in a hospital environment setup. Of course, when we come to ARBs, we have candesartan, which is 4 to 8 milligrams daily. Then we have losartan. Then we have valsartan here. And we also have telmisartan, which is not included here. Anyway, I don't know why it's not included. Anyway, these are the dosages, and these are the mean doses used. And when it comes to ERNIs, we have only one drug that is available, that is sacubitril valsartan combination, which is 49 milligrams of sacubitril and 51 milligrams of valsartan, which is given twice daily, and it is the most expensive drug among the various classes of drugs in this particular chart. Keep in mind, this is used in patients with class 3 or class 4 and beyond. So it is not somebody who you would start at class 1 or class 2. That's why it's important to know when to use these drugs. By the time your patients reach class 3 or 4, most likely you're going to need consultation with a cardiologist or a heart failure expert. Now let's move on to beta blockers. Beta blockers have been around forever. I have been in practice for more than 40 years and I have been using beta blockers for the longest period of time. They have the longest period of track history in terms of treating patients with angina, atrial fibrillation, and in patients with hypertension and heart failure. So there is a whole variety of experience when it comes to beta blockers. But beta blockers also do have some side effects. Beta blockers can cause AV conduction disturbances. They can cause heart blocks. So if anybody is having greater than second degree AV block, you need to be concerned about using beta blockers. So beta blockers have been shown to reduce morbidity, hospitalization, and mortality in patients with class 2, 3, 4 heart failure, and they are the mainstay in the management of patients with heart failure. It is exceedingly important to get them on as much as tolerated dosages of beta blockers to improve their symptomatology, their quality of life, and reduce hospitalizations. Okay, the beta blockers that are available for treatment of heart failure. I'm not talking about beta blockers available for hypertension. That may be primarily for hypertension. Here we have bisoprolol and carvedilol, which is the most commonly used drug, starting with 3.125 milligram twice daily up to a maximum of 50 milligrams twice daily. And we have carvedilol CR. I tell you, carvedilol CR, or the trade name Corex CR, is the most expensive drug when you try to fill a prescription. So be cognizant of what you're writing, because it can cost a fortune. Because I was doing a medical drug review for a patient as an insurance person, and I was shocked to find out it cost like $2,400 for a 3-month supply, whereas carvedilol probably costs you zero copay because it's a generic medication. So if you can get away with carvedilol twice daily, then you're far better off than using carvedilol CR generic or the brand name by the company, because even carvedilol CR generic is like $1,200 for 3 months. So that's a big ripoff as far as I'm concerned. Then we have the metoprolol, which is of course very commonly used, especially when I was working at the VA hospital. And metoprolol is very well tolerated, except for bradycardia, which becomes a major problem in patients with heart failure, with atrial fibrillation, and sick sinus syndrome. So as I said, all heart failure drugs are extremely useful in improving the symptoms, quality of life, reducing mortality, but they do come with a price tag. And in fact, I'm going to talk about on a separate slide about the significant effect or adverse effects of cardiovascular drugs used in heart failure that can affect the heart failure or heart function as such. Let's move on to mineralocorticoids, hydralazine, isosorbide, and for heart failure. Anyway, as I should have brought that chart again. Let me bring the chart again just for your benefit. Here's the chart, which I always bring it back. As you can see, mineralocorticoids had a 30% reduction in overall morbidity and mortality. Hydralazine had the best overall outcome. But these are all things that we don't start using in stage 1 or stage 2 heart failure. Please remember, there is a place for each drug, and each drug should be used in its place. And that's the knowledge that you acquire from presentations as this. Okay, let's get back to where we were. we are talking about hydralazine. And as I said, they definitely improve the quality of life. They reduce morbidity, they reduce mortality, they reduce hospitalizations. They do better than any other class of drugs. I'm talking about hydralazine, nitrates, and also the mineralocorticoids. Okay, and in patients taking MRA, whose serum potassium cannot be maintained at 5.5 milliequivalents, MRA should be discontinued to avoid life-threatening hyperkalemia, and that is the mineralocorticoid receptor antagonists such as aldactone or epralerone. I can't say that. Epralerone, if their potassium cannot be maintained below 5.5. So that's one of the indications or the warnings that we need to pay attention to and monitor their potassium levels more frequently as needed. Okay, here are the drugs spironolactone and eplerenone. Those are the dosages you can just see. And when it comes to SGLT2, I'm going to talk about that in a minute because that's in the next slide. But these are the two mineralocorticoids. Then we have the isosorbide dinitrite. Here's a combination, 20 milligrams of isosorbide and 37.5 milligrams of hydralazine. But it has to be given 3 times a day, and you can double the dose. And as I said, this has shown to have the best outcomes compared to all other classes of drugs in patients with heart failure. However, these drugs, namely nitrates and hydralazine, are used in class 3 or class 4 heart failure patients. Same thing with mineralocorticoids. They are not used in stage 1 and 2. So these are some important points to remember because you want to be in compliance with the guideline directed medical therapy. Now we're talking about SGLT2. These are the drugs that increase sodium excretion. These are the drugs that increase water excretion, which acts like a diuretic more or less, but it also improves left ventricular function, and it has improved overall cardiovascular mortality and reduced cardiovascular hospitalizations for heart failure. It is amazing because these are drugs used for treatment of diabetes, and because it causes sodium excretion, osmotic diuresis with glucose excretion, that has become a very significant player in the management of patients with heart failure. So these can be used whether these patients have diabetes or not. How about that? So in patients symptomatic with heart failure, SGLT2I therapy provides immediate economic value. I would say immediate improvement in quality of life. And here are the drugs: dapagliflozin. I don't know, when you go into a specialty like cardiology, you can't even spell or pronounce names in like dermatology or even endocrinology or, for example, pulmonary. So I have problem. Anyway, empagliflozin, 10 milligrams, pretty standard dose. It is given once a day. Remember those. And you need to make sure that when you're using these drugs, they are used appropriately at the appropriate time. You don't use them for class 1 or class 2 heart failure patients. Let's move on. Other drugs that have been tried in patients with heart failure, and some of these drugs like omega-3 polyunsaturated supplementation, which is like the EPA study that was done by Deepak Bhatt, which has been shown significant improvement in patients' symptomatology, in hospitalizations. So that's something to look into. Then we have the renin-angiotensin aldosterone system inhibitor, or AASI, and its effectiveness of potassium binders. These are some of the drugs which are in the works, but they don't have enough data to support routine use. and no benefit. In patients with heart failure with reduced ejection fraction, with specific indications like venous thromboembolism, like atrial fibrillation, previous thromboembolic events in it, anticoagulation is not recommended. So, in other words, anticoagulation is not a standard of treatment for patients with heart failure unless they have a history of DVT, atrial fibrillation, or previous thromboembolic events. So let me repeat it. Anticoagulation is not a standard of treatment. It could be one of your board questions. They may put down beta blockers, ACE inhibitors, ERNIs, then SGLT2I inhibitors, and anticoagulation. So anticoagulation is the wrong answer. Let's move on. Drugs with no proven benefits. And here's a long list of drugs that have not been shown to be beneficial, or of course the most commonly and widely used drugs for various indications like atrial fibrillation, hypertension. Now, the calcium channel blockers have not shown to be beneficial. In fact, they may be harmful in patients with reduced ejection fraction. Vitamins, minerals, supplements, hormone therapy, aromatherapy, all these have shown no significant improvement in symptomatology, quality of life, or longevity. And here are some of the things which are harmful. Look at this red box here. I'm not going to read each one of these. You just need to look at this. In patients with heart failure, non-dihydropyridine calcium channel blocker drugs are not recommended. We already covered that one. Antiarrhythmic drugs may increase the risk of mortality. See, we have patients with multiple PVC, short runs of VTAC, with heart failure, reduced ejection fraction. They are all treated with antiarrhythmic drugs, but generally speaking, most of the antiarrhythmic drugs do not improve the quality of life or mortality. Same thing with in type 2 diabetes, using dipeptidyl peptidase DPP4 inhibitors should be avoided in patients with heart failure. So you just, and non-steroidal anti-inflammatory agents may worsen the symptoms of heart failure. Okay, and here are some of the drugs which we already covered, like the mineralocorticoids and also SGLT2I inhibitors, and of course isosorbide. That I covered that one, and now we move on to the last couple of drugs that have been covered in this ACC AHA 2022 guidelines. That is ivabradine and digoxin. Ivabradine has been shown to be beneficial in patients with class 2 to class 3 heart failure with reduced ejection fraction, preferably less than 35%, who are already on guidance-directed medical treatment. It has been shown to reduce hospitalization and cardiovascular deaths. Digoxin. As far as digoxin is concerned, if the patients are in hospital with heart failure, fluid overload, and symptoms of worsening heart failure, digoxin does play a role in an acute situation. Let me underscore, acute situation. Digoxin in small doses may be useful in patients with atrial fibrillation with rapid ventricular response if you are not able to control the rate with beta blockers. So those are some of the indications, and when digoxin is used, we need to use the minimum amount of digoxin and keep the digoxin level close to like 1 nanogram per deciliter. Okay, ivabradine, the dose is 5 milligrams twice daily, and this is a Verisogot. I have not used this one, so this is another drug that's available. Digoxin, you want to use the lowest amount of digoxin and keep the concentration between 0.5 and 0.9 nanograms per ml. So there's a correct terminology for that drug. So ladies and gentlemen, and what is this one? There's another one, guanylyl cyclase simulators. I have not used this one. Side effects of drugs. Okay, there are significant side effects from all the cardiovascular drugs used in treatment of heart failure, starting with beta blockers, which can cause severe bradycardia, AB blocks, conduction disturbances, thiazides, which can deplete potassium and magnesium levels, and same thing with like antiarrhythmic drugs, which could be harmful. And similarly, we have diisopyridine, which is sort of a negative inotropic effect, which can worsen the heart failure. Sotalol, because of proarrhythmic properties and slowing of the heart rate, can have an adverse effect. Doxorubicin, which is an alpha blocker, may increase beta receptor activity because of unopposed beta blockade. So you can look at these, as you can, diltiazem, verapamil, nifedipine, they all have negative inotropic effect. So these are drugs which you generally don't use, but there are other drugs like flecainide or this sexagliptin. All these drugs that we use for heart failure may also have major adverse effects. So in conclusion, consider in class 2 to 3 heart failure, you use ivabradine. Then class 2 to 4, then some of these new drugs we are talking about, like verisagot, digoxin, and these polyunsaturated fatty acids, especially EPA and potassium binders. Oh, that's my picture. Anyway, let's get back to where we started off. So, ladies and gentlemen, this is a quick overview of the ACC/AHA 2022 guidelines for heart failure medical management. There are, as I said, this is 159 pages long. It covers everything from pathogenesis, from staging and medical treatment, equipment, medical treatment, device treatment, surgery, LVAD, transplant, all the way to the hospice. But here is the link to this website. I would suggest download this PDF file and keep it in your digital library for good, because this is something you'll be using for the next 4 to 5 years as a guideline for managing patients with heart failure. Thank you so much for watching this presentation. I am Dr. Nik Nikam, a cardiologist from Houston, Texas, and please do subscribe to our YouTube channel, and I will see you in the next presentation.